So I just wanted to, when Ray asked me if I would present a case, I just wanted to present a case where our iTrace was helpful to me. And I think that it gives you information you can't get any other way, and it's really exquisite. So this is a patient, it's an African-American young lady, 56, very young, right?
Right.
56 is young.
Oh, yeah.
And
Just a baby.
Just a baby. She really was juvenile cataract. So she came in with a high corneal astigmatism, came in for a cataract evaluation, had some real problems driving at night with glare and halos, terrible uncorrected vision, and look at her refraction. Just a huge cylinder. And this was her iTrace. And so you can see it's, you know, large amount of corneal astigmatism, not necessarily completely orthogonal, but huge amounts of astigmatic higher order aberrations and lower order aberrations actually for astigmatism. So here's the cornea versus internal aberration. You can see that her DLI was 3.31 and that she had some cortical change that shows up on her scan in the middle there. And this was her IOL master. So our typical way of dealing with a patient like this, look at the 9 diopters of cylinder on her IOL master. And we check these again with immersion as well, just to confirm. Especially in these cases, we really don't want to have to go in and either do an IOL exchange or an enhancement. They're abnormal eyes. Our theoretical formulas are not really made for these really abnormal eyes and abnormal anatomy. And so we want to do everything possible to minimize the residual refractive error in every case, even these complicated cases. So we do lots of different measurements, and you can see that in our initial measurements, you know, 116, 114 axis of cylinder looked like it was matching up pretty well. But then we did a Cassini, and in this case, as you know, it's also measuring posterior corneal curvature. And the total corneal curvature showed that the axis was maybe at 109. But if we looked at the normal way of putting in data that we do, we usually use the Barrett toric calculator. We put everything in there. It recommended an axis of 116 with residual astigmatism of 4 diopters. If we looked at the Toric Planner on the iTrace, it recommended an axis placement of 108, still giving about 4 diopters of residual astigmatism. So the plan was to put as much toric power as we could in a toric IOL, so that's a T9, and then to enhance that with the largest LRIs that I was comfortable doing with my laser. You could do larger ones, but I mean, I think when you get larger than about 45 millimeters of, 45 microns of paired degrees of arc, thank you, you are cutting through so many corneal nerves, then you know you're likely to really have some dysfunction of the ocular surface. So this was about as much as I wanted to do. And here's what she is at 6 months. 20/60 uncorrected, 3/4 of a diopter of myopia and spherical equivalent. 20/40 best corrected, so she does have some refractive amblyopia too. And ecstatic. Happy, happy patient. And we can then look and see, is the toric where we wanted it to be? Confirms the axis of 108. Really, 1 degree of rotation is what would be recommended, and that would only result in a 0.01 diopters of change in cylinder. So a happy patient, happy outcome. One thing that, as I was going through this case with Joe, he pointed out to me that the refractive prediction here on the Toric Check showed that she had maybe 2 1/4 diopters of cell residual, and that perhaps if we try pushing that for the patient, she may even see better than what we're refracting her at right now. And so now I have a job to do when I go home and try to see if we can get her just a little bit better.